This grand rounds. We're delighted that we've managed to get our coordination better than we have in the past, and so we've had the opportunity to bring together more than just the colorectal group, which I'm sure is the right way to do things, and I'm grateful to Dr. Bloom for helping us with this, and hopefully we'll do this many times again. We're very fortunate today to have with us one of the real thought leaders and opinion generators actually in colorectal surgery, Alessandro Fichera, who's come to us from UNC in Chapel Hill. Alessandro I've known for many years and is a true Italian in everything that means.
Yeah, nothing wrong with that.
No, well, you know, it has
We'll
its
see.
moments.
Yeah.
From Rome originally, where he did his medical school. Then went to Chicago as a research fellow and did residency in Chicago. Fellowship in Mount Sinai, along with some research, I think, in Mount Sinai as well.
No, it's just 2 clinical years.
Just
You know,
2
some
clinical
people
years.
take 1 year, others
Yeah.
take 2.
And then back to University of Chicago, where he headed up the colorectal group for a number of years before moving to Seattle, and then most recently became a division chief of colorectal surgery in UNC, which, as you know, is a very high-ranking institution. And we're very happy that he's here because one of our fellows, Paul Kaminsky, is a UNC product. So it's a small world. Alessandro has led a number of major initiatives in colorectal surgery, and in fact is one of the lead investigators for the Prospect trial in rectal cancer, which is a national trial. But today he's going to talk to us about his other great passion in life, which is inflammatory bowel disease and bowel sparing strategies in Crohn's disease. So welcome, Alessandro.
I don't need this, actually. Thank you, John. It's a real pleasure being here. I've been here before, trying to learn from the masters. There are some masters here, the tricks of and the skills of transanal surgery, transanal transabdominal surgery. I was impressed then. Getting to know you guys is even more impressive. University of North Carolina is actually known for being the place where Paul Kaminsky trained. So it's not, there's not nothing else but that. So I'm going to present sort of a journey that I took through the appreciation of inflammatory bowel disease and specifically Crohn's disease. A lot of the evidence, a lot of what I'm going to present is evidence-based, but there is also a lot of my own interpretation of what the literature says and what the experience over the years has taught me. So some of the stuff I'm going to tell you, you will not find in the literature. It's evidence that needs to be proven by studies that will never be done. So just take my word for it. If you think that I'm going to spend 45 minutes talking about stricturoplasties and fancy resection, that's not what I'm going to do. You save a bowel in Crohn's disease by doing the right operation at the right time with the right people on the right team with the right skills. So saving bowels, saving length of intestine in Crohn's disease is a process, and a process that involves many people. So I'm going to cover a lot of ground, try to explain my take on inflammatory bowel disease. You see often patients that come to you that have had a dozen operations for Crohn's, that go to the operating room every other holiday, and that's because we are not approaching these patients the right way. Crohn's disease is an aggressive disease, it's relentless, it comes back, it's recurrent, but you need to sort of have a plan so that you're not constantly chasing your tail, but staying ahead of the disease a little bit. I have no disclosures. This is my take over the years on inflammatory bowel disease and Crohn's disease specifically. As I said, you want to do the right operation on the right patient at the right time, performed by the right surgeon, supported by the right team. I've been at different institutions when I had great GI support, less than perfect GI support, and that makes a huge difference. As a surgeon, it's very hard for you to take the patient through the whole journey, all the way to surgery and to the postoperative assessment and management and prevention of recurrence. So you need the right team. And you need to be involved in all the steps, from diagnosis to postoperative medical management. And please, when you deal with this patient, don't think that a right hemicolectomy or an ileocystectomy for Crohn's is the same as a right hemicolectomy for cancer, because it is not. I want to present some cases. This is actually a case that Paul Kaminski helped me with. Help me. No, actually, this didn't have a complication because we did not take this patient to surgery. This was, I don't know if you remember, it was a 20-something-year-old guy, college student, still managed by his pediatric gastroenterologist who had terminal ileal Crohn's, managed with diet and occasional steroids. He refused biologics, presented to us with this MR enterography, a little bit of disease, asymptomatic. We gave him a surgery date of May 29th of this year. The guy went home, comes back 2 weeks later with inflammation in the terminal ileum, extensive inflammation, long segment. And Paul was on service, and Paul says, well, you know, this is not picking on Paul. It's very common. It happens all the time. Well, surgery is in 2 weeks. Rather than have him limp along for another 2 weeks, I would take him to surgery right away. And that is the only thing I would not do. We put this patient on antibiotics. We put this patient on steroids. We bridged him to biologics. We started him on biologics. He had a great response, and he's going to have surgery in December. Rather than go in when the patient is acutely active, I would wait, stabilize it, optimize it, get the disease under control, and do it later. And the same happened yesterday or 2 days ago when I was consulted by the same pediatric gastroenterologist on a 15-year-old with this mess, and same story. Steroids, antibiotics, watch her in the hospital for a few days, and bridge her to an elective operation. That's how you limit the amount of disease of intestine you're going to remove, decrease your risk of complication, and avoid a stoma, and do the procedure laparoscopically if you can. All right, so we're going to take you now through the entire journey of this patient to get to the optimal outcome of one operation and a limited risk of recurrence afterwards. The diagnosis is critical. I think that in 2019 coming up, there shouldn't be a CPT code for exploratory laparotomy. Now, obviously, I'm exaggerating, but for somebody with Crohn's disease, for a surgeon that does IBD surgery, going into a patient with Crohn's disease with the idea of doing an exploratory laparotomy or laparoscopy for that matter, that shouldn't happen anymore. We should have a preoperative roadmap, and you can use whatever you like to do. Here is a list of things you can do, and a lot depends on the skills and the available expertise in the institution. In Chicago, I had a great barium guy that's an endangered species. They don't exist anymore, so I don't have that kind of stuff. But you use whatever expertise you have in your institution, because this is a real case years ago of a patient that had multifocal small bowel disease, but also a duodenal stricture that in that segment of the intestine, perhaps you would not have looked specifically for it, and you would have gone after all these different strictures, rightfully so, and left with a very proximal problem that you did not address. And before going to the operating room in a patient like this, I want a roadmap. I want to know if I have to spend hours taking down adhesions to the left lower quadrant, right upper quadrant, or whatever, and run the risk of getting into an enterotomy or resecting more bowel. If I know that there is nothing there for me to mess with, I will not spend time doing that. So a preoperative roadmap, I think, is critical. It's critical also to know when to use the technology. This is a case of a capsule endoscopy a few years ago. that eventually got stuck into a stricture and required a resection to remove the stricture on somebody that could have been managed medically for longer. In any case, like in the old days, when I have a patient with multifocal small bowel disease, I take a Foley, I put in the intestine, I inflate the balloon to a diameter of 2 centimeters. That's a number that I took out of my hat. Actually, it was somebody else's hat, and he gave me the number, and I have been using that 2 centimeters. And I run that balloon up and down the small intestine to confirm the roadmap that I had before and to identify disease that perhaps sometimes is missed. And it doesn't matter, it doesn't mean that I'm going to address every little stricture I find, but that will give me the opportunity to describe to the gastroenterologist the extent and amount of disease that he or she will need to address or keep an eye on it. You mark it with a clip, you measure it, you report the distance from ligament of trice, whatever you do, but you give the treating physician that works closely with you a roadmap also of what needs to be done next. So, and you need to be involved with all of this. You need to be involved in this diagnostic journey. Now, the indication for surgery, I think, is really something that you can't teach. Every patient is different. Every indication is different. That's the beauty of Crohn's disease. You know, ulcerative colitis, no colon, no colitis. Crohn's disease is exciting and entertaining even as you get older because it's different every single time. And with all these new drugs, the phenotypes of Crohn's disease are changing dramatically. This is a algorithm that we had back in the days in Chicago for indication for surgery, and it's still valid nowadays. This is still what I use, but I highlighted obstruction because that's one indication that is often, in my opinion, misinterpreted and mismanaged by treating physicians, especially people that are not particularly familiar with Crohn's disease. Now, I'm going to give you some cases, and I'm going to tell you what is my take. There is no evidence in the literature whatsoever on what I'm going to tell you. This is just mostly gut feeling. This is a real case from Seattle, 21-year-old guy, a smoker, no previous surgery, recurrent small and large bowel obstruction. He takes no medication because he's totally unreliable. And you can see there a stricture there, dilated small bowel, more stricture in disease, and distal stricture there. This is a patient that I would not take to the operating room right off the bat. This is a patient I would spend significant amount of time talking about smoking cessation. This is a patient I would put on whatever medication he or she can afford, is a he, I believe, can afford, and try to decompress him, give him time to quit smoking, improve his nutritional status, and then take him to the operating room. To jump into this right away, you end up resecting more. You'll end up having a recurrence for sure, because this guy is smoking coming in, he's going to be smoking coming out. Maybe he'll change from this to that, but he will be smoking along his entire course. And if you go into this, you'll end up with an open operation likely, you'll end up with a stoma possibly, you end up with a complication, and you have not helped the guy get over the initial, this is the initial presentation of the disease. Am I going back? Yeah. Okay, this is a different story. This is a 23-year-old guy, non-smoker. He had a previous resection at age 10, so early diagnosis. Is a different type of disease. He has recurrent small bowel obstruction. He's taking biologics already, and he's compliant. You'll see here, let's see if I can. Nope. Okay, now I messed it up. See if I can do that. Good. You see a stricture there. You see dilated loops of small bowel. You see more stricture in disease down at the bottom. This is a patient that is already medically, has achieved whatever he can achieve. It's not smoking. I would decompress this guy. I would spend some time, perhaps adding a little bit of steroids to decompress him, empty his bowel, prep him if I can, optimize his nutrition, and do it relatively sooner than the other gentleman, but not jump in when he's, as you can see, having a partial small bowel obstruction, and make him NPO, whatever it takes to decompress him, do him electively, and avoid a problem down the stretch. This is a guy that likely will recur. This is aggressive disease. But I think you need to spend some time tweaking him a little bit, not like the patient I showed you before. I'm showing you this study. This is not a good study. The reason why I'm showing this is their conclusion. Patient with bowel obstruction needs to be medically treated first. There is no reason to jump into an operation in somebody that is obstructed for Crohn's disease. This is the only indication where you can, even in the presence of a complete obstruction, you can wait. You can decompress them. You can treat them medically, and most of the times they do get better. They will still need an operation, but I would do that operation when they are decompressed. For colonic stricture, obviously endoscopy is critical. I don't usually mess with dilating colonic stricture. If I know I'm going to do surgery, I would decompress them medically and proceed with surgery at the time. So by getting your patients ready for the best possible surgery is a way to save intestinal length. Now, and then you optimize them, and this is time consuming. Paul and I guess the entire class last year was involved with the treatment of the patient known as Skeletor. Skeletor is a 53-year-old guy. They gave him the name Skeletor, not, I mean, a 53-year-old guy that came with multiple small bowel fistulas, BMI of 13, I think, hasn't eaten in 4 years. It looked like Skeletor. That needed to be optimized. It took us months to do it, right? Every chief resident on service was familiar with him, and eventually had surgery, but there is a lot that has to be done. The guy was miserable, not particularly reliable, lives in the country, far away. You know, the easiest would have been, let's take him to surgery. Do something, give him a stoma, and then get back into that later. We didn't do that. We spent a lot of time. We did one surgery, and now Skeletor is now eating on his own and drinking on his own and doing okay. His BMI is now 19, I think. We're getting there. And as I said, there is a lot you can do. I'm not afraid of putting patients on steroids preoperatively. I would rather take a patient to surgery in sort of remission on steroids or biologics or both, rather than take somebody in an acute flare, not medically controlled, just because I want to get them off the medication. If somebody has been on steroids for a long time, it takes a long time for the potential side effects of steroids to wash away from the patient. So weaning them for a couple of weeks before surgery, the only thing you're going to achieve is to get the patient to flare again. So I don't make any efforts whatsoever to wean them of steroids. And the same is for biologics. If there is sepsis, you got to drain it. You got to find a radiation intervention radiologist that is willing to do it. Decompress them with NG, with steroids, whatever you need to do, improve the nutrition, and get a roadmap. And sepsis is a big thing, because that's a way, going into somebody's belly that has an active infection is the way to get postoperative complication. This was a case, this I think goes back to Chicago, of a woman that had what I call an on-table recurrence of Crohn's disease. There is not such a thing. If somebody leaks after surgery, it's technical. It's not an on-table recurrence. Crohn's disease doesn't recur that fast. She was treated with every biologic you can find at the time. This is a few years ago, so probably only infliximab at the time. And it did not have recurrence. She just had an anastomotic leak. We drained her, we optimized her nutrition, we took her to surgery, we took her off all the medication pre-op, because we felt that this was not really a recurrence, and she did okay. You can only do this if you have a team of gastroenterologists that are willing to work with you. Nutrition, it's key, and we haven't talked about smoking yet, Paul. We will soon, but nutrition is key. This paper is old, and I think their message was, by doing TPN, you probably avoid, you decrease the length of intestine, you're going to resect. The message actually is slightly different, I believe. These are patients that were made MPO, were treated, and were put on TPN. You optimize them, and that's why you resect the less intestine. Not because of the TPN per se, but because of the waiting, resting the intestine, and improving their nutritional status. And that's what I still, some 30-something years later, that's still my approach to a lot of these patients. Now, you need to know what you're getting yourself into and when to do your surgery. This is a list of known risk factors for recurrence. There are some that you can intervene on and others you can't. The phenotype of the disease, there's nothing you can do about it. The location, there's nothing you can do about it. The age of diagnosis, those are all things that you cannot have an impact on. There are a couple of things that you can work on, and one is smoking and one is postoperative complication. And I'll show you evidence to suggest that those are critical in the long-term outcome of these patients. When you smoke, not only you're at high risk of recurrence, but you're more likely to have an indication for surgery than a patient that has Crohn's disease and doesn't smoke. This has been shown over and over. This is a systematic review and meta-analysis. And still, in the birthplace of smoking in the US, we do not spend enough time consulting and advising our patients that they need to smoke. A little anecdotal experience, and you may think that I'm a cold-blooded murderer. I had a patient that came to the emergency room with one of Paul's colleagues. He had another country boy, not particularly sophisticated, smoking like a chimney, not compliant, perforating disease, terminal ileum, abscesses all over the place. We drained, antibiotics optimized, took him to surgery. He was really in bad shape. We didn't put him back together, gave him an ileostomy. We tell him, go home, come back when you don't smoke anymore. Comes back in a month, he's still smoking, comes back in 3 months, still smoking. I said, as we said before, come back when you quit smoking. He went home and tried to commit suicide. He didn't succeed in that either. He still has an ileostomy. I'm now closing that guy. There is no reason to put him at risk of having another operation in a guy that is not going to see the doctor anyway, and he can live with an ileostomy. This is critical. We don't do enough of a good job to advise our patients, to educate our patients about this. And as I said, not only you're more likely to have the first operation, but you're more likely to recur. And there is so much intestine you can resect. There is so many operations you can do. So this is really an important point to make with our patients. Now, we're all surgeons, so let's talk about surgical technique and what can we do from a surgical point of view to decrease the risk of recurrence. And as I said before, I haven't mentioned stricturoplasties yet. So see, there is a lot more to this story than stricturoplasty. As it is in cancer, the outcome of patients with inflammatory bowel disease that have postoperative septic complication is worse than patients that don't. This is one of the many studies that show that indeed, if you have a complication, septic complication, you're more likely to recur surgically. Now, for the students and the residents in the room, there are several ways to describe recurrence of Crohn's disease: endoscopic recurrence, clinical recurrence, and surgical recurrence. Obviously, as surgeons, we focus more on surgical recurrence, and this study shows that the risk of surgical recurrence in patients that have intra-abdominal septic complication, IASC, is even higher than smoking. So this is something that it's important to do. And that's what tells me that medical optimization before surgery is critical. In order to address recurrence of Crohn's disease or prevent recurrence of Crohn's disease, you need to understand it. You need to know where it happens, why it happens, and what you can do to prevent it. We did these studies a long time ago now in Chicago, and we looked at the patients we treated primarily for the first operation at the University of Chicago, and then recurred and came back to us. So definitely not a perfect study. Obviously, there were patients that were lost to follow-up. This was not to determine the incidence of recurrence, but just to characterize the recurrence. And as you can see here, this table is a little bit complicated. You know, and when you're young, you try to be cool, but basically what this says is that if you do a small bowel to small bowel anastomosis, the recurrence is more likely to happen at the anastomosis per se. And if you do a colo to small bowel, like a terminal ileal disease, the recurrence was more likely to occur right before. The bottom line is, for simple, not particularly complicated first-time surgery, the recurrence happens in or around the anastomosis, suggesting that there is something there that locally happens that makes the recurrence more likely. And now we know more about this, and we know the importance of the microbiome, we know the importance of changes in the local environment due to fecal stasis and flow of stool. So this actually, in retrospect, makes a lot of sense. So what can we do? Well, the first thing you think is, well, maybe we can change the type of anastomosis we give. And studies have been done with sort of mixed results about the size of the anastomosis. And people have gone into hands-on versus stapled and side-to-side, end-to-end. What really matters, in my opinion, you can do it with glue, with duct tape, with sutures, with staples. That's not the point. The point is the size of the anastomosis. And as I will show you some more evidence later, is also what part of the intestine you're going to use for the anastomosis. We know that Crohn's disease starts at the mesenteric edge, and the recurrence starts at the mesenteric edge, and that sort of then grows and spreads with like the creeping fat, and creates a problem. If you keep the mesentery out of the anastomosis, are you perhaps delaying the recurrence or preventing the recurrence? But let's take it one step at a time. The wider the lumen, the less likely it is for you to have stasis at the anastomosis, and the less likely it is for you to have microbiome changes at that level. This is one study. Obviously, you may have noticed, I'm only showing you the evidence that support my belief and not the opposite. But this is a grand rounds. It's not a scientific presentation. I can present whatever I feel is indicated. But obviously, there are studies that contradict this. Not contradict, but don't show the same difference. And here we're talking about surgical recurrence on the right side, which is really what matters to us. And the wider the lumen, the less likely it is to have a surgical recurrence. Now, this is another study that compare stapled end-to-end to, hands-on end-to-end and stapled side-to-side. They concluded that the staple side-to-side is better. As I said, I don't think it matters how you do the anastomosis. I think it's the configuration that makes a big difference. This is in terms of endoscopic, I believe, and surgical recurrence as well. So there is data out there that supports the volume theory, the size theory that I was mentioning. Now, I was fortunate enough when I was in Chicago to meet Professor Kono. He's a surgeon from the island of Hokkaido. They had an earthquake the other day. He's fine. I talked to him a couple of days ago. He's a very smart person. Japanese surgeons are typically quite skilled and very thoughtful. And he thought about all the risk factors locally that impact of an anastomotic recurrence. Vascularization, innervation, the size of the connection, the presence of the mesentery, the distortion that sometimes it happens, especially in an end-to-end. You can imagine small bowel end-to-end. What prevents the anastomosis from kinking and twisting, especially once you start having endoscopic recurrence. And he described what is now known as the Kono-S anastomosis, which is an anti-mesenteric hands-on anastomosis that follows, that sort of takes into consideration all these factors that I mentioned before. This is the way you do it. You end up resecting the bowel very close, resecting mesentery very close to the bowel to preserve innervation and vascularization. You divide the mesentery perpendicular to the bowel, and I'll show you why. You create a supporting column by sewing the two staple lines together to prevent distortion. You make an anti-mesenteric enterotomy, 7 centimeter long, 7 centimeter wide, not long, to allow a very large anastomosis supported by a column in the back that doesn't twist with intact vascularity. And that's the way it looks. Obviously, he presented this technique after 5 years of follow-up and shown, and I'll show you the data, very intriguing data. And as I said, he followed all this principle, he thought about it, he has a supporting column, anti-mesenteric configuration, limited disruption of blood supply and innervation. And indeed, it resulted in a lower incidence of endoscopic recurrence, if nothing else, less severe endoscopic recurrence. Endoscopic recurrence, and I'll show you data on that, is the exception, not the rule. I'm sorry, it's the rule, not the exception. It happens very often in patients that have had an ileocolic resection. If you scope them at 1 year, you will find some changes in the area in majority of these individuals. So here, the number of patients with evidence of endoscopic resection, endoscopic recurrence was not significantly lower, but the median score, the severity of the recurrence was significantly lower. But more importantly, surgical recurrence at the anastomosis at 5 years of follow-up was 0. And you may say this is just delaying recurrence. That doesn't matter. This is a lifelong disease. Even delaying recurrence it's a win in my opinion. After meeting Professor Kono, I started doing this myself. He actually flew one time when I was doing my first one and told me, don't do that, don't do that, do the other way. And eventually taught me how to do this anastomosis. And we looked at our first 46 patients, and we found exactly the same. Now, granted, the follow-up is short. You have no surgical recurrence. We were not expecting surgical recurrence. But the average Rutgers score was significantly lower than anything you have ever read anywhere else. And this is all comers, smokers, recurrent disease, ileocolic, colonic anastomosis, all comers. It says there, as you can tell. And this is how you actually do it. You'll see some very nice pictures. Those are from Japan, and you see some pictures. Those are mine. This is a small bowel anastomosis from Japan, and follows the principles I showed you before. You can see on the left, he actually ended up resecting quite a bit of intestine. And he told me that if he has sites of disease that are next to each other, you could get away with a stricturoplasty and a resection. He would just resect the whole thing. He's so confident in his results that he would resect everything and do an anastomosis that way. The mesentery is perpendicular. This is the stump. He puts it together, creates a supporting column, and that's the S stays for supporting column. Then he does a longitudinal enterotomy to allow a transverse lumen of 7 centimeters. And then I do 2 layers, he does 1 layer, and so on, anastomosis. Those are the pictures from the US. It's ileocolic anastomosis. The beauty of this also is, and I don't know if you were involved with a recent patient, Paul, it came with a chronic obstruction from a decade. He lost his insurance, he managed with liquid diet. His proximal small bowel was this big, the colon was this big, and it doesn't matter. You create the lumen by doing the enterotomy. It doesn't matter the size of the intestine. You can use it for any segment, any size, any segment of intestine you want to put it back together. I do 2 layers. He does 1 layer. That's the way it looks at the end. We then compared our data not that long ago. The disease in Japan is slightly different. It's primarily small bowel. In the US, it's terminal ileal disease. And despite the fact that we had a different length of follow-up. We started this operation a long time ago, larger patient population, and also was multi-center in Japan. This was only University of Chicago at the time, a shorter follow-up, but the surgical recurrence rate is significantly lower than what you've ever read anywhere else. The only 2 recurrences are from Japan. I pick on Professor Kono for that even to this day. And obviously the length of follow-up is what makes us look perhaps a little better. But the bottom line, the combined 170 cases, the recurrence rate is significantly lower. There is a randomized trial, now international, going on. University of Washington, Mass General, Cornell, a center in Israel, a center in Japan, and a center in Italy. We're trying to open it at UNC, still working on the IRB. The study will close before I will be able to pass it through the IRB at UNC, but the idea is to compare a side to side to the Kono anastomosis in a randomized fashion. Last time I checked, we had 44 patients enrolled for a target of 80 patients. Primary Crohn's disease, primary terminal ileal disease, no other sites of involvement. try to keep a clean patient population. Now, we need to talk about stricturoplasty a little bit, and the stricturoplasty idea is very intuitive, right? You have a patient that has multifocal disease, short segments or not, or patient that have had a lot of resections before. You want to save intestine, you want to relieve the symptoms, and that's what you do. You can't do it on everybody, and that's why it is important to work with somebody that can send you patients that are ready for the least invasive operation you can do. If you go into the abdomen of somebody that has a long segment like this, stenosed or inflamed or thickened, there is no stricturoplasty you can do. This is a resection, and you move on. This is the father of modern stricturoplasty in Crohn's disease, Heineken-Mikulitz, and those are the options that you have. Conventional procedure is the short segment Heineken-Mikulitz. Most people in the audience know what I'm talking about. FINI is more of an intermediate type of approach, depending on the length of the disease. And for very complex, multifocal, short bowel type of patients, it's a side-to-side stricturoplasty. And the technique, as I said, everybody knows. That's the way I do it. I send a biopsy on every stricture I do. There have been reported of cancer, reports of cancer at the stricturoplasty site. I mark the stricturoplasty site with a clip for future identification in this day and age of dilation of strictures in Crohn's disease. That is sort of in the GI literature, at least it's every once in a while it comes back with mixed results. I try to, again, offer to the treating physician that works with me the best possible long-term, longitudinal roadmap for management of this disease. FINI is shown there for longer segment of disease. I have to say that I don't do many of those. If there is a long segment, I try to do a resection. I've had a couple of situations where you have to go back to resect what then becomes a big diverticulum, creating stasis and creating bacterial overgrowth and all sorts of different problems. Now, to do a stricturoplasty, you need to have some room in between of normal intestine to be able to space them apart. And a situation like this or like that, it's hard to find a landing point for that stricturoplasty. And a situation like this where you see proximal dilation. So these are the patients, together with patients that have already lost a long segment of intestine where a side-to-side isoperistaltic stricturoplasty is indicated. I have to say I haven't done many of those because, again, it's a very limited indication, a very extreme indication, I would say. Now, there are a bunch of those that have been done in the country, and Dr. Michelas is keeping a registry on those. People have gone creative and done side-to-side on the ascending colon, tried to avoid a ileocystectomy. I'm not sure. I think this is only for patients that are on the verge of becoming intestinal cripple. And this is the way it looks at the end. It's one of the few I've done when I was, again, young and restless. It's hands-on. It's very time-consuming. I don't listen to music in the operating room, but I sing, which is not good for the rest of the team. So the longer operation, the more they suffer. And this is actually the same person that came back with recurrence in another segment of disease, and we exteriorized this and took a picture to see how it looks. There was an elegant study when Dr. Michelas first described this endoscopic surveillance of these stricturoplasties, where because they had short gut or not a lot of intestine, they were able to actually get an endoscope in the stricturoplasty site and took biopsy and showed complete regeneration and resolution of disease in the segment that had this stricturoplasty. Obviously, these are high-risk patients that will likely recur. Now, you may think, all that sewing and stuff, this is inflaming tissue. You'll have a lot of complications. And indeed, that's not the case. Oftentimes, I stretch that indication for a Heineken-Mikulitz and do it a little longer, and you're concerned about this huge suture line. It actually is it's quite safe to do it. I would say that I probably have seen more bleeding than than leak at the stricturoplasty site personally. In any case, the complication rate as shown in this study is not astronomical, and more importantly, the recurrence rate at the stricturoplasty site is significantly, it's low. It's quite low. These patients are high risk, so they do recur. If you see there, the recurrence rate is not 0, but they recur elsewhere. These are multifocal, small bowel disease, so the high risk of recurrence. But at the stricturoplasty site, the recurrence rate is only 3%. Now, with all that evidence, a recent study from OHSU seems to suggest, or is suggesting that based on NISQIP data, we're doing less and less stricturoplasty. And I really don't know why that is. We're using more biologics that supposedly are creating more stricture in disease, or the healing of Crohn's results in more strictures on biologics, but we're doing less and less stricturoplasties. I'm not really clear, I'm not really sure why that seems to be the case, but stricturoplasty is a great alternative to resection and should be used at the right time, again, on the right patients. Now, when the surgery is done, our job is not over. Even if you have a great team of people working with you, you need to work with them, first of all, to provide them with the best possible intestine for them to treat, and also with the best possible roadmap for them to understand what needs to be done. And you guys need to work, and we need to work together. Now, as I said before, recurrence after ileocolic resection, endoscopic recurrence is the rule. This is a landmark study. Granted, there were no biologics. There was really no prophylaxis for recurrence after surgical remission in Crohn's disease. But if you scoped in 1990 a patient after an ileocectomy, 80% of them will have some endoscopic recurrences. And these are the type of recurrence I just mentioned before. Endoscopic, clinical, radiological, if you want to call it that way, and surgical. And these patients will progress, if untreated, to surgical recurrence. And this is this is the way the new anastomosis looks, with the different degrees of endoscopic recurrence. So you do a great operation, the patient is a smoker, or has had disease since age 10, or whatever, has risk for recurrence. What can you do to prevent it other than do the right anastomosis and avoid complication and force them? I will use the term force them to quit smoking. Well, our colleagues have thought about this, and they thought, you know, if infliximab works to achieve remission, why don't we use it to prevent recurrence? Well, the answer is simple. It's expensive and has side effects. So perhaps we should select the patients that need the benefits, not need the benefit from an aggressive approach like this. And Miguel Riguero, now at the Cleveland Clinic, formerly at Pittsburgh, thought, okay, let's do a quick, small study. I had great surgeons at UPMC that do a lot of Crohn's. The complication rate is low. We're going to select a group of patients. We're going to put them on biologics from day one, or nothing, or placebo. And the difference in endoscopic recurrence was dramatic. And we went from the rule almost to the exception, as you can see here. Now, this is a one-size-fits-all approach that clearly cannot be recommended to everybody. So, our gastroenterology colleagues that usually are very clever in designing their clinical studies designed this study that I'm not sure was really designed the right way. But anyway, this is the PREVENT trial, looking at the use of biology. You can read it yourself, to prevent surgical, to prevent recurrence. That's the key, prevent recurrence after surgery for Crohn's disease. And what is the problem with this study? The problem with this study is that they designed the study to, with a primary endpoint of clinical recurrence, the secondary endpoint of endoscopic recurrence. I showed you the 1990 Rutgers study that showed that the endoscopic recurrence, at 1 year, you see it. The clinical, not so much. And that's why, in my opinion, this was a negative study. The study did not meet the primary endpoint of clinical recurrence. It did meet, however, the secondary endpoint of endoscopic recurrence in patients that were on biologics. But this is a negative study. So, and in a way, I'm glad that it's a negative study, because positive study here would have meant for the general public everybody goes on biologics, and that's not the answer. The answer is we should select who goes on biologics. So what do we do in this day and age? We have options. You can watch and wait for them to develop symptoms. That graph showed you that once you develop symptoms, the cat is out of the bag, right? Should we treat everybody? We just said we shouldn't, because there is the 45-year-old guy that has short segment stricturing disease and the terminal ileum, and you have the 16-year-old person that has multifocal small bowel disease and is going to college, is going to smoke. Those are very different people, right? Should we use a personalized approach based on a risk stratification? And that's the answer. Leading question, obviously, showing only the evidence that goes to support my theory. And how do you assess this patient? You assess this patient by doing early postoperative colonoscopy. It is pretty much standard of practice in the GI ward to scope this patient 6 to 12 months from the original operation, unless, again, they come and I'll show you high risk when these patients are treated right away, scope them and assess their endoscopic recurrence, and then adjust therapy based on that. Miguel put together this very nice diagram, an algorithm. The patients were divided between low, intermediate, and high risk based on the factors that I showed you before. And again, there is the spectrum from the 45-year-old with short segment stricturing disease that doesn't smoke, and the 16-year-old with multifocal disease that started smoking and is not compliant to medication. And the risk of postoperative recurrence is different. Patients that had a high risk are usually treated right away, and colonoscopy is used to adjust therapy, and the low-risk patients where colonoscopy is used to decide who needs medical therapy. And this can only work if you all work together. I think this is the best evidence we have with the limited ability for us to predict who is going to recur. This is the best way we have to provide patients with the right treatment after the right operation. So to put this all together, I think I'm almost right on time. You need to do the right surgery at the right time on the right patient. You don't have to do surgery. And that often, that's what I see. A patient comes to my clinic, I'm going to cut him. No, you need to do the right surgery on the right patient at the right time. And sometimes it takes months to get Skeletor to a point where he can survive the operation and actually get better. I think you need to know what you're getting yourself into. Exploratory laparotomy and laparoscopy is something that should, for the most part, disappear. You need to optimize your patient, whatever it takes, time, effort, money, phone calls, whatever it takes. You need to demand smoking cessation, not just encourage. You need to really work with your medical counterpart. Everywhere I've been, I found 1 or 2 GI guys that you can work with. And now I have this pediatric gastroenterologist that seems to be willing to collaborate and understand your philosophy. Your philosophy is take the patient to surgery when he or she is optimized. Have several options. You should be able to do laparoscopic, open stricturoplasties, any kind of stricturoplasty, resection, different kind of anastomosis, robotic if you want to add that to the picture. Understand the need for a stoma, when to do it, when not to do it, how long to keep it. Drain before, how long you keep your drains, when you take them out, and so on and so forth. Then, after you've done all of this, you need to make sure that they don't recur. And then you need to work with your gastroenterologist. And unless they are high risk, and they should be treated right away, endoscopy dictates what you're going to do next. And then adjust your therapy for the 3 groups based on what you see on the endoscopic findings. Unfortunately, I don't do routine colonoscopy, so I don't have that opportunity. But for people that do colonoscopy, this is the way to do it. Just scope your patient and work with your gastroenterologist. And this is the end. This is sort of a summary of my journey into this disease. It's very exciting disease, and it's getting more and more exciting as we introduce more drugs. A little bit like rectal cancer with all these different ways to treat the disease. And this is, in my opinion, as exciting. It keeps you entertained and always thinking, even when you go to the operating room on the table. So thank you very much, and I'll be happy to answer any questions.